Alright guys, let's get busy talking about our uterine pathologies. We're going to be talking specifically about uterine pathologies relating to different layers of uterine tissue. So let's go ahead and do a quick review of those layers to orient ourselves to talk about pathology here in a couple of minutes. So here, if we look at our uterus, we're going to have layers that are going to start closer to the uterine cavity and then move our way more out. So if we look here at the level that is most closest to the uterine cavity, which I'm outlining in purple, this is going to be the uterine functionalis, and this is composed of glandular tissues, and this is the portion of tissue that is grown and then shed with each menstrual cycle. Now, if we went one layer further back, we're going to have this blue layer, which I'm highlighting, and this is the uterine basalis, and this is a population of cells that is responsible for regenerating the functionalis every month after menses. And so you can think of it as a regenerative layer, and it's important in order to support the functionalis above. And then if we go one more layer out, we're going to have this much thicker layer, which I'm highlighting in orange, and this is going to be our uterine myometrium, and this is the part of the uterus that is responsible for contraction and support, and it's going to be the outermost layer that we talk about in these pathologies. So now that we've talked about that review, I want to also mention that I'm going to be highlighting things in red, and that's going to emphasize trauma as the inciting portion of our pathology, and I'm also going to be highlighting things in green, and that is going to signify hyperplasia. So there's going to be kind of two layers of highlighting going on. The layer that we're talking about in terms of the uterine layers, and then red or green for trauma or hyperplasia. So let's go ahead and get started by talking about our adenomyosis. And I'm going to be highlighting here in blue because this is all about the uterine basalis layer. And essentially what happens here is we have hyperplasia of our endometrial basalis layer, and this is going to cause invasion of endometrial tissue into the uterine myometrium. So remember here, we're talking about hyperplasia here, and we're talking about our blue basalis layer. So if you go back to our diagram, essentially this blue is growing out of control into the myometrium, and this is going to lead to pathology. I'm going to erase this increase in blue here because we need to use this diagram later, but you guys get the idea of what is happening, and this is all going to be due to increases in estrogen. So if you have a patient with PCOS or on hormone replacement therapy, or perhaps an ovarian tumor that is producing estrogen, we are going to get increases in estrogen, and this hyperestrogenic state is what is causing this hyperplasia of the basalis layer. So we're expecting a patient who is between 30 and 50 years old complaining of dysmenorrhea or menorrhagia, which are fancy words for pain with menstruation or heavy menstruation with a lot of blood, so dysmenorrhea and menorrhagia. And this makes sense, right? If our basalis is growing into the myometrium, we could imagine this would cause pain, and if it's growing out of control, perhaps it's contributing to a bigger functionalis, leading to greater amounts of bleeding each month. Now, here's the highest yield part of this pathology, and it's going to be this description of a soft and boggy, uniformly enlarged globular uterus. This is so high yield. This is how they will describe adenomyosis to you. The histology findings of this are not as high yield as the physical exam description that I just described. It is so high yield, and we also may present with tenderness in the uterine or pelvic area as well. And in terms of our management here, it's going to be all about reducing this hyperestrogenic state. So we can use GnRH agonists like leuprolide, which are going to kind of reset the pituitary hypothalamic axis, and they're going to bring that estrogen level back down to a normal amount. And we can also move on to hysterectomy if the basalis has just grown way too far into the myometrium and it needs to be removed altogether because it's causing excessive symptoms that cannot be treated medically. Let's move on now to talking about endometrial hyperplasia. And you'll notice that I have switched to purple now because we are talking about our uterine functionalis layer, or the layer where we have our glandular tissue. This is the layer that is grown and shed every month with menses. And essentially there's a very similar process happening here, but now we're talking about the functionalis layer. So we have increased estrogen, and this is leading to hyperplasia of the endometrial glandular tissue. And I want to highlight in green here over our hyperplasia to note that this is an error in hyperplasia here, and that's going to be important. They like to note the difference between too much growth, not enough growth, or trauma, and we're talking about too much growth here. And our etiology is going to be very similar. It's going to be states with really high estrogen, so PCOS, estrogen supplementation, nulliparity, late menopause, or estrogen producing tumors. These are all going to predispose a patient to developing endometrial hyperplasia. And in terms of our presentation, this is usually going to be postmenopausal bleeding. Remember, all bleeding postmenopause is considered abnormal, but if if we were to have a premenopausal patient, we could have any type of abnormal uterine bleeding. So this is going to be bleeding that is not expected. This is going to be bleeding outside of the normal menstrual cycle. In terms of our diagnostics, this is going to be where the high yield part comes in. In adenomyosis, we were talking about the physical exam findings, but in endometrial hyperplasia, it's going to be all about the histology. And what is that histology going to sound like on exam day? It's going to sound like proliferation of glandular cells with atypical cells showing extensive loss of cell polarity. Those are all going to be hot words describing our endometrial glandular hyperplasia here. In terms of our management, we can use progesterone supplementation like progestin because this is going to combat the growth causing effects of estrogen. So if we give them progesterone, it's going to combat and kind of rebalance out that hormonal balance that we talked about a lot in our videos on the menstrual cycle. We can also move to hysterectomy if there's evidence of cellular atypia that is concerning for malignancy. Finally, let's talk about our Asherman syndrome, and I'm going to switch back to our blue color because we are back to talking about the basalis layer. And essentially in Asherman syndrome, we are going to expect some type of uterine trauma, and the uterine trauma is going to lead to destruction of our endometrial basalis layer, and this trauma is going to be replaced with adhesions, scarring, and fibrosis, and this is going to lead to failure of regeneration of our endometrial tissue. And so I'm going to go ahead and highlight here again over uterine trauma with red because we talked about trauma as being our red color here for describing the primary insult. So you can imagine here, if we go back to our drawing, that if we were to like do some red lines here to show some trauma from perhaps a uterine curettage or dilation and curettage procedure, that is going to have difficulty regrowing here, and that's what Asherman syndrome is. And so if we have trouble regrowing our endometrial tissue, we're going to expect a patient who presents with amenorrhea because they cannot regrow their endometrial lining, so it's impossible to have a menses if that's the case. We can also expect infertility or abnormal uterine bleeding because you can imagine if one portion of the endometrium is growing but the other one is not, this might cause some abnormal bleeding at mid-month or something like that. We can also expect pelvic pain because there's scarring and fibrosis here, and also recurrent pregnancy loss because we are not generating a full, well-working endometrial lining. So really the thing to be focusing on in terms of Asherman syndrome is all about this prior uterine trauma. So some description of a uterine surgery or a miscarriage or an ectopic pregnancy where they had to go in and do something surgical that is changing the lining of the uterus and predisposing a patient to scarring is what we're worried about with Asherman syndrome. So in terms of our high yield review, it's really important to know our layers of our uterine lining. Are we talking about the functionalis, the basalis, or the myometrium? And then it's important to know if we're talking about hyperplasia, like in the case of adenomyosis and endometrial hyperplasia, or are we talking about trauma, like the case of Asherman syndrome? Once we have that down, it's important to nail down some hard-hitting facts. So in the terms of adenomyosis, it's all about this physical exam description of this boggy, uniformly enlarged globular uterus that's going to be really high yield. And then in terms of our endometrial hyperplasia, we're going to expect proliferation of our glandular cells as a really high yield point. And then for Asherman syndrome, we're looking for that trauma. So some history of some sort of uterine surgery or curettage, that's going to point you towards our Asherman syndrome. So I hope this video was helpful for you guys. Can't wait to see you guys in the next one. Bye!